Hi students, so I will be discussing about the high-risk newborn. And these newborns have a greater than average chance of morbidity in 28 days, making survival rate at danger. You have to review what or how a healthy newborn is for you to be able to understand better how to care for a high-risk one. First, how do we identify a high-risk newborn? These are the risk factors associated with their diagnosis. First is maternal age. These are the extremes of age, the very young and the very old. Second is concurrent maternal disease conditions. A mother with a pre-existing problem prior to pregnancy. Mother already has hypertension, diabetes, infection, and the like. Third, fourth, and fifth are our previous topics on pregnancy, labor delivery, and postpartum complications. So all these complications will definitely affect the fetus, and thereby, once born, this newborn may be considered high risk. Number 6 is unhealthy maternal lifestyle. Mothers who smoke, mothers who drink alcohol, mothers who take substances, mothers who have poor nutrition, mothers with inadequate rest or sleep, mothers who are stressed. These are the examples. And 7 are congenital problems. So these are the newborns who are born with an existing problem associated with the different systems of the body, which we will further discuss as we go along the pediatric physiologic disorders. These are the 8 priorities when caring for a high-risk newborn. We can recall that in EINC, there are 4 core steps when caring for a healthy newborn. But if you are caring for a high-risk one, doing these 8 priorities are very essential for survival rate to be good. Let us now discuss them one by one. First is initiating and maintaining respirations. The ultimate prognosis of the high-risk newborn depends greatly on how the first moments of life are managed. Remember that most deaths occur in the first 48 hours after birth, and this results from a newborn's inability to initiate or maintain respirations. Also, normally, most neonates are newborn with some degree of respiratory acidosis, but the spontaneous onset of respirations rapidly corrects this. You know very well that a healthy newborn can do this without a problem. But in a high-risk one, there could be difficulty in the first few hours. That is why immediate newborn care is very important. If a high-risk newborn has difficulty with the onset of respirations in the first few hours, yet that child survives, there may be neurologic difficulties which occur because of cerebral hypoxia. These now are the different respiratory patterns. You can go over them. These are all self-explanatory. Read and understand each one. Eupnea, tachypnea, bradypnea, apnea, hyperpnea, Kind-Stokes respiration, Bios respiration, and Kussmaul breathing. When evaluating respiratory distress, there are 4 grades. Respiratory distress is simply defined as a difficulty of breathing in a newborn, which are associated with many factors. But first, let us try to describe what each grade is. Grade 1, tachypnea and nasal flaring. These are the early signs of respiratory distress. If you see these early signs in a newborn, you would definitely hold on, assess further, and intervene immediately so that the newborn will not develop further or more severe grade of respiratory distress. Grade 2 description is all grade 1 characteristics plus retractions. Retractions are characterized by chest injuring. This is visible to the naked eye. That is why when you're caring for a high-risk newborn in the neonatal ICU, one criteria is the chest of these newborns are exposed so that nurses can easily assess if there are retractions. Grade 3 respiratory distress are is characterized by grade 1, grade 2 descriptions plus expiratory grunting. Grunting is not visible to the naked eye. It is audible. You can hear it. It's a sign that there is difficulty breathing because there's already a narrowed airway. Grade 4 respiratory distress is grade 1, grade 2, grade 3 descriptions plus cyanosis, which is bluish discoloration of the skin. It means there is already hypoxia, profound hypoxia, plus disturbed consciousness. So, what are the organized steps in resuscitation? First is to establish the airway. Second is to expand the lungs. And third is to maintain effective ventilation. You will see in the box 26.2 the factors that predispose newborns to respiratory difficulty or respiratory distress in the first few days of life. So please go over them and read. Now, remember that if breathing is ineffective, the fetal circulatory shunts fail to close at birth. Please try to recall and review again fetal circulation. One circulatory shunt I am talking about is the ductus arteriosus. It's the communication between the pulmonary artery and the aorta. This should close immediately after birth. But then again, I've said that if a newborn's breathing is ineffective, ductus arteriosus may fail to close. Why? Since the heart's left side is stronger than the right side, blood flows through a patent ductus arteriosus left to right or aorta to pulmonary artery. This creates an effective pump action. Because there is a struggle to breathe and circulate blood, the infant uses glucose quickly, causing hypoglycemia, and this compounds the initial problem. So first, there's ineffective pump action. Next, there could be hypoglycemia. For all these reasons, resuscitation is very important. To establish an airway, you first need to clear the infant's oral or nasal mucosa of any secretions. In the picture, you will see the nurse suctioning the newborn using a bulb syringe. First picture, suctioning the oral mucosa. Second picture, suctioning through the nasal passages. What are the principles? When suctioning a newborn, always suction the mouth before the nose. Neonates are nose breathers. So if you put immediately the suction or the bulb syringe in the nose, you occlude their breathing right away. Second, suction not more than 10 to 15 seconds. Suctioning more than that will stimulate the vagus nerve or will cause vagal stimulation. And vagal stimulation can further cause bradypnea, dyspnea, and cyanosis. Question: can you use the same bulb syringe for the mouth and the nose? Yes, because they have the same normal flora. Another question: what if the bulb syringe is so big it cannot reach the secretions in the posterior part of the mouth and the nose? What you can use next are the actual suction tubes or gastric tubes. They are small enough to reach the posterior mouth and the posterior nose. So in the first picture, a suction tube or a small feeding tube in the mouth, and in the second picture, a suction tube or a small gastric tube to suction the posterior nose. Next, what if the secretions are weighed down the respiratory tract? It's so difficult to suction just using the suction tube or the gastric tube. That's when you do the intubation. Intubation is the process of putting an airway down the lower respiratory tract. Nurses do not intubate ideally. Specialized nurses can do this with a special training, but we assist doctors to intubate. The first thing you need is a laryngoscope. The laryngoscope has a battery on it, and you can see that the pointed part is drawn inward the mouth. From the word laryngoscope, it visualizes the larynx. It has a light on it so the doctor can easily visualize the larynx. And then, with the use of the laryngoscope, the doctor will now insert the ET tube. ET tube has different sizes. We usually use the small sizes for the horns. And the tape or the secure tape, when the ET is in place, we tape it in the mouth. This picture shows the process of intubation. So the doctor is holding the laryngoscope and the ET now is in place. So when the ET has been attached, you secure it using the tape from the word ET. Endo, it's within the mouth, trachea, until the trachea. So there's already a patent or an access down the respiratory tract. When there is already an ET in place, you can easily suction now the lower part of the airway. You insert the suction tube inside and then follow the same principles. Suction not more than 10 to 15 seconds. Another question: can you use now the same suction tube for the oral, nasal, and the ET secretions? The answer is no. You always use a different suction tube for the ET secretions because they have a different normal flora. This now, after suctioning, will give you a patent airway. That patent airway can now be an access to be used in order to deliver oxygen therapy. For you to be able to make sure that this is always patent, of course, check for bilateral breath sounds, the right and the left lung fields. After establishing the airway, the next step is to expand the lungs. This is a bag valve mask. Ambu bag is a common brand name. It's a self-inflating bag which can deliver oxygen manually. You pump on the self-inflating bag portion, and then it delivers oxygen at different rates. For a newborn, we usually use this bag valve mask with or without the face mask. You can see in the picture that there is an attached face mask that can be detached. Use the bag valve mask in the sprout or the opening fits that of the ET or the endotracheal tube attachment. Here you will see that a nurse is using a bag valve mask with a face mask, giving oxygen at a rate of 40 to 60 breaths per minute. 40 to 60 because it is the normal or the average RR of a newborn. Box 26.4 shows us the drugs commonly used in newborn resuscitation. Go over them and read. Now, if a child's respiratory depression is caused by a narcotic given to the mother during labor, you can give another drug to the newborn. You can give naloxone through UV or umbilical vein or IM 0.01 to 0.1 mg per kilo. If there is maternal drug abuse, which is now the reason for the child's respiratory depression, cautiously use naloxone as it can cause acute withdrawal symptoms to the newborn. The third step is maintaining effective ventilation. First step, establish the airway. Make sure you have a patent airway. Second step is to expand the lungs. You have to make sure that the lungs do its function. Inhale, exhale. And the third step is to make sure that this breathing pattern is continuous and effective. What are the important principles? First, I mentioned a while ago that a child with respiratory distress is usually undressed. The chest is exposed in the ICU so that nurses can easily assess for retractions. This is chest in drawing, visible to the naked eye, or grunting. It's audible, usually heard during expiration. Letter B, position head elevated 15 degrees. This is to prevent increased intracranial pressure. C, keep the infant warm. We all know that even healthy newborns are at risk for hypothermia. Therefore, high-risk newborns are also predisposed to having hypothermia, and hypothermia can have so many complications. Letter D is to suction secretions. So recall also the principles behind suctioning. These are just some of the pediatric oxygen supports we can use to maintain effective ventilation after making sure that there is a patent airway and after making sure that the lungs have expanded. So first is via nasal cannula, another is by hood, third is through a CPAP, and last is a ventilator. This is oxygen therapy via nasal cannula. Nurses prepare its setting, FiO2. This is the partial concentration of oxygen. Usually, it is not more than 3 liters per minute. Newborns can usually accommodate 0.5 LPM, 1 LPM, 2 LPM. 3 is slightly high, but some newborns can also be given that setting. This is now a general oxygen setup. I know that all of you are familiar with it, but let us familiarize. First, there are two types of oxygen inlets or reservoir. The first is oxygen via a tank. Another are oxygen sources via the walls or an inlet within the room. The first attachment you can see after the tank or the inlet is an oxygen regulator. The oxygen regulator is where you can see the small ball. That ball rises up if you open the oxygen. So the unit of measurement is LPM or liters per minute. The maximum LPM is 15, but that is for adults. Children or newborns in particular, because of their very small noses, can only tolerate, again, as mentioned earlier, 0.5 LPM, 1 LPM, 2 LPM, 3 LPM. After the regulator, you can see the humidifier. The humidifier humidifies oxygen. That is very important because oxygen is dry air. You need to humidify it, to moisten it, so that when oxygen enters the airway, it will not cause trauma to the airway. And then after the humidifier is now the oxygen tubing, and that tubing is where the oxygen cannula is attached. This is a typical hospital bed head unit, and I just want you to familiarize yourselves with the common or the standard colors so that you will not confuse yourself. Green usually is oxygen support. Compressed air is usually yellow. What is compressed air? If a child would need less than 100% of oxygen, you use compressed air for that. For example, you are to give 70% of oxygen. So what you need is to compress 30% to provide a 70% oxygen. That's how this is used. And last, one of the important ports also in hospital bed unit is your suction, where you can suction your patient's secretions. This is now the oxygen hood. It's typically a hood. It should be transparent over the face of the newborn. And there you can see the oxygen tubing is attached to the hood. Setting is also in FiO2. Oxygen hood delivers more than what the nasal cannula can give. If the nasal cannula's unit of measurement is usually in LPM and the maximum is around 3 LPM, oxygen hood's FiO2 is usually in percent. Maximum is 100%. Again, for example, if a doctor would order prepare O2 hood 70%, so you will be needing the compressed air. You prepare 30% compressed air to give 70% oxygen. Another consideration, O2 hood and nasal cannula are best for early signs of respiratory distress, because for the late signs or severe signs, a child or a neonate would need the other oxygen therapies. Third is the nasal CPAP. CPAP stands for Continuous Positive Airway Pressure. Its settings are FiO2 and PEEP. FiO2, maximum 100%. What is the minimum? Minimum ordered by doctors is usually 30%. Always remember that room air, the air we breathe, is 21%. The Earth's atmosphere contains 21% of oxygen, so you can never prepare an oxygen therapy lower than that. The second is the PEEP. PEEP stands for Positive End Expiratory Pressure. It means that this machine will make sure that a newborn's lungs remain inflated at end expiration. That is very important in order for lungs to not collapse. It prevents atelectasis. Because it's a pressure, the usual measurement is in mmHg. Normally, PEEP is set as 4 mmHg. Some are at 5 or at 6. So basically, when we talk about CPAP, which can also be given via ET, CPAP will make sure that the lungs remain inflated even during expiration. This is very beneficial for newborns who have premature lungs. The most complicated now of all the oxygen therapies is the use of a mechanical ventilator or respirator. Its settings include FiO2. PIP stands for Positive Inspiratory Pressure. PEEP stands for Positive End Expiratory Pressure, the same with that in CPAP, and RR is Respiratory Rate. Who is eligible to use ventilator? From the previous newborns we have discussed using cannula, hood, and CPAP, these newborns still have spontaneous breathing. But if a newborn's breathing is not spontaneous, that's when a ventilator comes in, because the ventilator can deliver breaths or RR. It's like the artificial lungs of the baby. Again, FiO2, partial concentration of oxygen, maximum is 100%, minimum is 30%. PIP, inspiration. Because it's also pressure, it is in mmHg. And it is how big the lungs can inflate. Maximum or the usual levels of PIP for newborns are 18 to 24 mmHg. PEEP, I mentioned a while ago, it's 4 mmHg, but sometimes there are 4, 5, or 6 mmHg. For RR, the machine usually delivers a breath of 40 to 60 per minute. But sometimes when babies are so premature, for example, some ventilator machines deliver RR at a rate of 100 breaths per minute or more. It depends on the prognosis of the baby. There are also different types of ventilator modes. But the most common type of ventilator mode we use among neonates is the SIMV mode, Synchronized Intermittent Mandatory Ventilation. The SIMV mode delivers a preset tidal volume at a preset rate where the baby can breathe spontaneously between ventilator breaths. So it depends on the machine. You click on the machine for different modes, but SIMV mode is usually used. The use of a mechanical ventilator is very beneficial for newborns to maintain effective ventilation. But as you care for a newborn with this oxygen therapy, you also have to consider its possible complications. One is barotrauma. Air is compressible, but tissues are not. High lung pressure damages tissues of the surrounding lungs. That is why weaning is very important. What do you mean by weaning? When you wean, you lower the oxygen based on the stability of the newborn's vital signs, especially the oxygen saturation. You can also make use of arterial blood gas results to be able to wean. For example, a newborn requires 100% of oxygen. For a matter of 8 hours, with that level of oxygen, the newborn's oxygen saturation is always 100%. The arterial blood gas results reveal good results too. That's why it is possible to wean. Therefore, you can decrease the oxygen saturation of the baby. Let's say decrease it now to 90%. As the child goes along with the weaning process, decreasing the level of oxygen, barotrauma is prevented. Second is tension pneumothorax. It's a collection of air or gas in the pleural cavity due to, again, the high pressure of ventilation. And weaning is also important to be able to prevent this. But if there is already pneumothorax despite weaning, or if weaning is still impossible, tension pneumothorax can be corrected with the use of chest tubes. Third is GI complications. Peptic ulcer with hemorrhage can result from, again, high lung pressure. You would see that usually these are all resulting from high lung pressures. Let me go back again to the fact that our normal lung can only tolerate 21% of oxygen. Take note that mechanical ventilation always provides a pressure higher than that. And a pressure higher than the normal 21% can lead to all these possible complications. Gastric dilatation can also occur from air swallowed due to the artificial airway or the endotracheal tube. That is why this is very important. If you will recall the previous picture in the slide, the newborn with the ET has an orogastric tube. It's automatic. When you insert ET to a newborn and you attach an oxygen therapy such as ventilator, you will also have to attach an OGT. The orogastric tube should be open at the end. It should be open so that there would be air decompression from the stomach so that you can also prevent gastric dilatation. Fourth is hypotension with decreased cardiac output. This is due to decreased venous return, again because of high lung pressure, but is transient. Fifth is increased ICP. Cause is decreased venous return also because of pooling of blood in the head. Again, we prevent this as we make sure that the newborn's head is elevated. We usually use a donut in the head. The donut is a pillow which will catch the head of the baby and prevent it from moving around. 6 is fluid imbalance. Again, increased lung pressure uh, will stimulate problems of ADH secretion. It can cause increased antidiuretic hormone secretion, and an increased ADH will cause water retention. So we always monitor intake output when a child is on mechanical ventilator. We always regulate uh, fluid intake. We always measure urine. We always weigh the patient daily. If now, based on oxygen sats and arterial blood gas results, the neonate is in a good status. After weaning, there is already a good status. We can now prepare for child's extubation. Extubation is the opposite of intubation, which means you can now remove the ET. You can now stop the mechanical ventilator after weaning, which means that the latest FiO2 of the child has been weaned from maybe 100%, it was now weaned to 30%, or room air, 21%. You have to assess good ventilatory status first, which means this child can now tolerate lower oxygen therapy levels. Prepare an intubation set in cases where, right after extubation, the child might fail to maintain effective ventilation. C is to prepare ordered oxygen therapy after ventilator. Most usually prepare an oxygen hood, but only at an FiO2 of 30%. Just so the baby will not right away need to be set in a room air setup. The last is to prepare racemic epinephrine nebulization. From the word nebulize, you need a nebulizer and give racemic epinephrine. When you say racemic epi, you are to prepare 0.1 cc of epinephrine plus 4.9 cc of NSS to make 5 cc. This 5 cc is divided into 3 doses and you give it as a nebulization every 15 minutes. Racemic epi nebulization is given right after extubation so that the bronchioles will remain dilated. Right after removing the ET, racemic epi will promote a good and patent airway and prevent bronchospasm. The second step is establishing extrauterine circulation. You will do a closed chest massage if there is no audible heartbeat or if the heartbeat is below 80 beats per minute. It is holding the infant with fingers supporting the back and pressing the thumbs against the sternum or depressing the sternum with fingers approximately 1 or 2 cm at a rate of 120 times per minute. You can see the picture A or B. Also, in addition to positive pressure ventilation and cardiac compression, you can also add 0.1 to 0.3 ml per kilo of epinephrine via ET in order to stimulate cardiac function. These now are important monitoring machines when a child is in the neonatal ICU: pulse oximeter and physiologic monitor. This is a pulse oximeter. There is a probe attached either to the hands or the feet. In an adult, we usually see it in the fingers, sometimes in the ears. But because for a newborn, fingers are too small, we basically attach the probe in the hands or in the feet. The pulse oximeter measures the oxygen saturation. It's the peripheral oxygen saturation. Maximum and the best percent is 100%. 95% and above is okay. But if you see 95 and below, for a healthy newborn, it means the patient or the baby is desaturating. For a very preterm newborn, an O2 sat of 88 and above may be acceptable. It depends again on the prognosis of the baby. You will also see in the pulse ox another important vital sign. Here in the picture, you see 96. 96 means 96% oxygen saturation. That is good. The other number you see is 125. 125 is the heart rate. Pulse oximeter usually measures the heart rate too. For a newborn, 126 is considered, or 125 is considered a normal heart rate. Another is the physiologic monitor. It is a machine which measures almost all the vital signs, including an echocardiography or the ECG. You can see there heart rate, blood pressure, RR, sometimes temperature, sometimes blood pressure. It is a physiologic monitor of almost all the important vital signs, but nurses should not rely on these monitors. Having these monitors in the ICU does not mean that you will not anymore get the vital signs manually. Always remember, you are more intelligent than machines. These machines are intended for monitoring purposes so that the machine can alarm anytime if there would be problems, but always confirm it by getting the actual vital sign using your individual equipments. Another important consideration to check for effective circulation is assessing a child's neurologic status. First is to note the level of consciousness. You can do this using the Pediatric Glasgow Coma Scale. Another is to measure head circumference daily. You have to take note of the basis, an average newborn. A healthy newborn's head circumference is set at 33 to 35 cm. Measuring it is very important to detect for possible problems of the neurologic system. You can detect the possibility of developing hydrocephalus or increased intracranial pressure. Third is through the use of intracranial monitors as needed. This is an invasive procedure, and you will be able to study this during your higher medical surgical nursing courses. Fourth is to record any seizure activity if there is any. We will be discussing seizure also in the pediatric physiologic diseases for the nervous system. This is the Pediatric Glasgow Coma Scale. It has 3 parts, mainly the eye, the verbal, and the motor. Eye has a perfect score of 4, which means the eye is spontaneous. Verbal has a perfect score of 5. It has been modified for a pediatric or a child level. And the motor has a perfect score of 6 if the extremities move spontaneously. You add all the responses Perfect score is 15. It's the best response, meaning a child is in his or her best level of consciousness. There is a mild brain injury if pediatric Glasgow coma scale is 13 or less. There is moderate brain injury if score is 9 to 12. And there is severe brain injury. The child is comatose if the score is 8 or less. Blood transfusion is another important intervention to be able to make sure that the circulation is well established. Nurses administer blood. Take note that there are different types of blood that can be administered. One is fresh whole blood. It is when you give all the components of blood, namely RBC, WBC, platelet, and even the plasma. Another type of blood transfusion is the packed RBC. You only give the RBC component of the blood. C is when you give only the plasma component of the blood. And lastly, only the platelet concentrate. Remember also that when you give blood, you give it in a span of 4 hours, except the platelet concentrate. Platelet concentrate can only be given in 1 hour. Other than that, the blood is spoiled. Or more than that, the blood will be spoiled. For neonates, it's also important that you aspirate the blood through syringes. This is for an accurate amount. Take note always that when you give blood to neonates, we always prevent congestion. We always prevent the risk of congestive heart failure. So it is important for you to give blood at an exact amount. The first picture shows blood aspirated in a syringe and given via syringe pump, which is set in ml per hour. The second picture shows the blood delivered via UV or the umbilical vein. For high-risk newborns, we can use the UV site other than peripheral IV sites for long-term IV therapies. In this example, you are to give PAC-RBC A positive 30 cc now. The nurse prepares and will set the syringe pump machine to how many ml per hour. Please recall that all blood transfusions except platelet concentrate can be given in 4 hours, which means you have to divide 30 into 4, and that will make 7.5 ml per hour. This means that in 1 hour, you will consume 7.5 ml of blood to make 30 cc in 4 hours. Also, I mentioned a while ago that when giving blood transfusions to neonates, we always prevent the risk of congestion, especially congestive heart failure. Because of this, sometimes doctors would order giving furosemide diuretic middle and after blood transfusion. When you give furosemide, you always check the blood pressure prior to administration. Furosemide increases urine output but decreases the blood volume, so it can cause hypotension. Let's say, for example, this PAC-RBC 30 cc is given at 1 p.m. Mid-BT would mean at 3 p.m. I will administer Furo. Post-BT or after BT would mean I will give another Furo at 5 p.m. So that is furosemide mid and post-BT. This is now DVET, the double volume exchange transfusion. From the previous blood transfusion photos I showed you, it is just a simple blood being transfused via the umbilical vein. But in the vet, we remove abnormal blood components and replace it with donor blood, which means you are now using two types or two axes, which is the UA and the UV. Umbilical artery, where you will remove all blood. Umbilical vein, where you will administer the donor blood. The vet usually takes at around 4 hours or more. And this is especially true and a good intervention for children with blood dyscrasias. Phototherapy is an intervention to treat jaundice. Jaundice is yellow color of the skin. It results or it can result because of a breakdown of fetal to adult RBCs. Liver enzyme is needed to convert one of its breakdown product, which is indirect bilirubin. Indirect bilirubin is the one causing the yellow color of the skin. It must be converted to direct bilirubin so it can be expelled in the circulation and will not cause jaundice. But if a child is preterm, there is a higher chance that the liver enzymes are not effective. There is a higher probability that the liver is immature to not cope with the conversion of the indirect to direct bilirubin. If a child has 10 to 12 mg per deciliter value, this child would need phototherapy. That's the value of the indirect bilirubin, but usually lower values for preterm. Phototherapy light activates the liver in order to convert indirect to direct bilirubin. For healthy newborns, we also prevent jaundice. That's why we put them, or we encourage mothers to put their children under the early morning sun. Considerations: light 12 to 30 inches above bassinet or incubator. Second is to undress, but cover genitalia and eyes. You have to cover genitalia, especially for the males, to prevent infertility. You have to cover the eyes because exposure of retina to the light can cause retinal damage. Third is monitor temperature, assess turgor, and possible dehydration. Light is hot, so always check if there are hyperthermia signs, and also the risks of insensible water loss. Stool may turn bright green and urine may be dark colored. These are signs that phototherapy has been effective, which means the indirect bilirubin is slowly being excreted out of the body. The third is to maintain fluid and electrolyte balance. You can see in the picture central line sites and IV line sites. Central line sites are big veins which are very near the heart or the heart's aorta, and nurses do not insert these line sites. It's only doctors or specialized doctors who can insert central line sites. There could be a jugular vein or the femoral vein, while IV line sites or peripheral line sites, which usually are inserted by nurses. So there you can see a scalp vein, metacarpal vein, as well as the others in the arms and the legs. The IV cannula, the hep lock, and a butterfly are what you will be needing or preparing prior to inserting an IV access. It's very important that to maintain fluid and electrolyte balance, you have to weigh the neonate daily. It's the most accurate way to measure the infant's fluid electrolyte balance. Second is to record I and O. And third, measure electrolytes such as sodium, potassium, chlorine, calcium, and the others. When a child is usually high risk, sometimes breastfeeding is contraindicated. So if a child is on NPO, remember that for the first 24 hours, we usually give D10 water. But if a child is still on NPO after 24 hours, that D10W should be replaced with D5IMB with other minerals. That is to prevent electrolyte imbalances. Remember also the principles when you are giving IV fluids. You are computing IV fluids. In the second picture, you can see there a macro set and a micro set. When computing drop rates, always consider drop factors. A microset's drop factor could be 15, 20, or 25 drops per ml, while a microset's drop factor is always 60 drops per ml. Another thing to consider is checking for any signs of dehydration. So please try to study this table whether a child is developing signs of mild, moderate, or severe dehydration. These are the different intravenous replacements we can give a child in order to maintain fluid and electrolyte balance. Dextrose, I mentioned a while ago that D10 water is usually given for children, especially if on NPO, but only for the first 24 hours. Saline solutions, it can provide hydration. It's very similar to plasma. Ringer solution is also for providing hydration, but with several salts dissolved in water. Lactated Ringer solution is also similar to saline, like plasma, but contains a base, causing less acidosis. It is best for sepsis and trauma. Dextran is a good volume expander. It can be given in parenteral nutrition when children cannot tolerate enteral nutrition. It is given as an IV. Lipids are providing high levels of calories for children. Please try to review also the different isotonic, hypotonic, and hypertonic solutions which you usually encounter in the RLE. It is very important to regulate temperature in all newborns, whether healthy or high risk, because we all know that all newborns are prone to hypothermia. Normal temperature is 36.5 to 37.4. The safest way to get it is through the axilla, and most accurate but can cause vagal stimulation is the rectal route. The newborn baby emits heat energy in the form of infrared electromagnetic waves. These are through conduction, convection, evaporation, and radiation. You all know this, so please review them also. We always have to make sure that you regulate well a newborn's temperature because Preventing hypothermia will also prevent a lot of its associated complications, namely hypoglycemia, acidosis, and respiratory distress. These are some of the ways to regulate temperature. Heat lamp or drop light is one of the easiest ways to regulate temperature. Although it is easy to use, it is not the most accurate one because we do not know how hot the lamp or the bulb emits. That is why for very small newborns, we do not usually recommend using heat lamp or drop light. Also, take note that these babies are all undressed. Recalling our discussion a while ago, I mentioned that babies in the neonatal ICU are usually undressed so that you can easily observe for signs of retraction. Going back now to heat lamp or drop light, there is another equipment that can be used to regulate temperature well by accurately giving off the required heat, and that is through the use of a radiant warmer. The radiant warmer is a machine which can emit heat at a specified level. If you want the heat to be 37 degrees Celsius, you just set the machine and click 37 degrees and that will emit the required heat. It is open compared to another machine which also emits a specified level of heat, and we call that incubator or isolate. This is the incubator or isolate, similar to a radiant warmer. If you want 37 degrees Celsius, just click or set the machine as is. What is the difference? It is closed. Radiant warmer is open. So there are two more advantages when using this machine. First, incubate. The child's temperature is well regulated inside because the machine is not open. And it is said that when a child's temperature is very much regulated, the speed of growth is more effective. So incubator is very fitting for newborns who are small. Their growth is faster if you put them in a well-regulated temperature. Sometimes you call this machine also as isolate. It is also regulating temperature at the same level you want, the same heat you want, but it can isolate the patient. That's why you call it isolate. So sometimes you can see big babies inside. They are not there to become incubated. Sometimes big babies are inside isolates to isolate them. And isolating them means you are being protective of the child because of risk of infection, or you are also protective of other children because you isolate the child from the rest. That's why sometimes you use two terms, but you are talking about the same machine. It's incubator or isolate. Last is the very famous skin-to-skin contact or kangaroo care, which, according to EINC, is the best way to regulate temperature for a healthy newborn. But does that mean you cannot use this method in a high-risk newborn or in a baby with ventilator or a baby who is intubated? The answer is yes. You can still use skin-to-skin contact and kangaroo care, but you have to be very cautious. You have to always monitor the baby and the mother. When establishing nutritional intake, we always have to check the baby's ability to feed. If not, the baby might need to be placed on NPO. But if the baby can feed, remember that we can still give breast milk even if the baby cannot tolerate breastfeeding. Breast milk can be given via supplemental feeds, bottle feeding, drop feeding, or cup feeding. The breast milk uh, may also come from donor mommies, not necessarily the mother's baby. And then, the feeding can also be given via incrementals. When we say incrementals, we can begin with small amounts of breast milk and then increase them at a slow pace until the child can tolerate normal and large amounts. It can be given via enteral or parenteral. For enteral, could be breastfeeding, the normal, bottle feeding, drop feeding, or cup feeding. The first picture shows drop feeding. It's a syringe without the needle. The breast milk is given on the sides of the cheek at a slow pace. The cup feeding is the second picture. And the third feeding is through orogastric tube. Take note that between nasogastric and orogastric tube, OGT is the best route for newborns. Rationale, babies are nose breathers. The fourth picture is gastrostomy or jejunostomy directly on the lower GI tract. And the last picture shows parenteral nutrition when enteral nutrition is not possible. The nutritional intake, example, lipids are given via IV using a syringe pump. Important considerations: always assure the correct caloric requirement for the age and the weight. That is why we usually give feeds via incrementals. Measure abdominal girth every 8 hours or every day. Basis: upon birth, you have to check the abdominal circumference. In a healthy newborn, in a full-term newborn, in an average size newborn, abdominal circumference is usually 1 to 2 cm smaller than the chest, or 29 to 31 cm. If ever you measure abdominal girth increasing every day, these are signs of impending GI problem, and one of which a sign that may manifest necrotizing enterocolitis. Third, note quantity and characteristic of gastric residuals or vomitus. Always take note that when children feeds, it should be upright and there should be no residuals or vomitus. Always observe for the amount, for the consistency, for the smell, if there are any gastric residuals or vomitus. And fourth is to check stool specimen for blood. These are signs or possible signs of gastrointestinal bleeding. To prevent infection, hand washing is the single most effective way to do so. Remember that when a newborn has contracted an infection while in the neonatal ICU, it could drastically complicate the newborn's ability to adjust to extrauterine life. Furthermore, infection can increase the metabolic oxygen demands and will cause further respiratory distress. So aside from hand washing, there are other ways to prevent infection which you all do similar when you do your duties in some special areas. That's why when you enter ICUs, you have to wear your cap, mask, scrub suit, and a separate shoes only for that area. Establishing parent and infant bonding is a very important intervention also when caring for a high-risk newborn. As you can see in the picture, parents can still carry or hold neonates who are intubated or inside the incubator. When doing so, nurses must assist carefully. If not, you can ask parents to just talk to the baby or maybe hold their baby's hands inside the incubator as a form of bonding. There should be no visiting hours for them. Parents can visit them anytime they want. Be certain also that the parents of a high-risk neonate are kept informed of what is happening to their baby while inside the ICU. When providing developmental care, let us consider the theories of Erikson, Freud, and Piaget. According to Erikson's psychosocial theory, a neonate is on the trust versus mistrust phase. First and foremost, neonates must trust their primary caregivers, and that primary caregiver should be their parents. But what happens if they are inside an ICU? In this case, when mothers visit their mothers can feed their babies, their mothers can change their clothes, their mothers can clean them, their mothers can change the diapers. In the picture, you can see that even if the baby is on OGT, it's the mother who assists the baby when doing so. Take note that you can only ask the mothers to do these basic things. You cannot ask mothers to suction for them, to inject medications. What I am telling is an activity which is providing the basic needs of a newborn. According to Freud's psychosexual theory, a newborn is in the oral phase. But what if a baby in the ICU is on NPO? You can give intermittently pacifiers to suck on, but do not provide pacifiers all throughout the day. It can cause uh, air to enter the GI tract and maybe lead to further complications. According to Piaget, newborns are in the sensory motor stage. They use practical intelligence when it comes to their cognition. They appreciate colors. They appreciate hearing beautiful sounds. So as you can see in the picture, the baby's incubator is filled with toys, different colors of toys with mobile sounds to stimulate the senses of the baby. To summarize, this picture depicts a high-risk newborn confined in an ICU. So you have to recall again the 8 interventions that we have discussed, and all these are applicable when we now try to understand and study the different newborn disorders.